Hi, Annie.
Hello, everybody.
So Annie, if it's okay with you, we're just going to take up just a few minutes at the beginning. Joyce had one quick clinical update for Bartlett, and then we'll get started with your talk, which everybody's really looking forward to. So I think Joyce is on, and we've got a fairly good number of people. Joyce, do you want to?
Yeah, sure. I'll go ahead and just give this brief update. So Bartlett has the opportunity to participate in something called Sprint, which is being sponsored. I think it's from the Department of Medicine, where there's a team that will help us look at our workflows, look at pain points in delivery of clinical care, and try to help us optimize the workflows, incorporate, identify some areas where we could maybe enhance Epic in that process. And then also where we will block off time in clinic schedules for people to have a one-on-one time with a trainer on Epic, so that they can look with you on how you're using Epic and help providers to optimize the Epic work. So the 2-week intensive time is May 9th through May 20th. So you're going to be getting more information about this. I will figure out the best way to send this to you, but there's a place you can email about any types of things you think that we should focus on during this opportunity we have over the next few months working with them leading up to that 2-week period in May. So I just wanted to verbally let everybody know about this, and there's going to be more information to come.
And Joyce, maybe also we could put things in the Teams about that if as another place, landing place. And I know after the conference last week, I did hear from a couple people who were asking if they had access to the Teams folder. And just to put out there again, if anybody doesn't know how to navigate to that, please let me know. I think most people are on the list. I checked last week and it was pretty comprehensive, but we're always happy to have, can always add people, of course, there's no problem whatsoever, or even show you how to get there, because hopefully it has some useful things.
We have a Bartlett Sprint channel. So perhaps in our Bartlett channel, and maybe Eileen, we can strategize. I feel like we have everything in the one, channel, in the one section in Teams about COVID and I don't know if there's a way to maybe reorganize it, but I can put information about accessing that Teams channel in our Bartlett channel.
Yeah, I totally agree. I think one thing I'll just, from having used the Teams in the research group a bit too, keep in mind that everything that's been posted ever that's an actual item is also in files. So if you just go to the files tab, that's sometimes easier to find things like clinical updates or things like that. And you can tell by the date they were posted, as opposed to scrolling through all these threads and to try to find resources. So thank you to Yuka and Joyce for all the things you're putting in there. And then just as a schedule for the next few weeks. So today we're very lucky to have Annie, who I'll introduce in a second. Next week is part of the 31st annual Clinical Care of the Patient CME conference. And we have 2 talks next week, geriatric care and people living with HIV from Dr. Laskow, and then primary care updates from Gail Birkenblit. So obviously high yield. And then the following week, we're going to do some HIV cases. Anyone who has a patient who's interested in discussing, please let me know. And then the following week after that, Derek Fine has agreed to come and talk specifically about renal cases. So I have 1 or 2 already, but please, if you have specific questions about renal patients or issues that have arisen in your patients living with HIV, please let me know. And then the week after that is back to the HIV Care Conference, again, that time with updates in diabetes management from Todd Brown and the ART pipeline from Ian, one of our fantastic pharmacists. So then enough preamble. Now today, Annie Antar has been doing really amazing work, both in gathering data and people living with HIV and their experiences and clinical outcomes in COVID, but also in trying to understand basic science around, in particular, long COVID, has agreed to come and share things with us, and hopefully repeatedly in her presentation will remind us to refer people to her study.
That's right. Yes, sorry. You probably have heard me repeat 10 times how we're looking for patients who are living with HIV and tested positive for SARS-CoV-2.
No, no,
So
no,
thank-
I mean it. Please remind us. Like, I realized I forgot someone.
Yeah, yeah, no, we appreciate all your referrals. So thank you so much, Eileen, for the invitation, and the CFAR for the invitation to talk today. So today I want to go over just a few key highlights and updates about long COVID, about recognizing it in your patients, risk factors, and a couple of suggestions for referral and clinical management. And then after that, I want to tell you a little bit about this study that we're doing specifically to look for long COVID incidence and kind of biomarkers for this in people who are living with HIV. So first, I want to go over the common symptoms and sequelae of SARS-CoV-2 infection, go over some risk factors, and then tell you about the study. So, this has been pretty exciting last couple of years with COVID. I think everybody has been very busy dealing with COVID as well as their previous research in clinical life. But we witnessed two diseases emerge, not just acute SARS-CoV-2 infection, but also long COVID. So I just wanted to go over this timeline. So in February 2020, actually kind of right during and before the CROI of that year, the World Health Organization China report was released. And so this gave us, at least here in the West, our first glimpse of SARS-CoV-2 infection. And surprisingly, it showed that people who had severe disease took several weeks to recover. And in March 2020, patients who had COVID started gathering on social media and sharing their experiences. And many of them were finding that even after discharge from the hospital, or even if they weren't hospitalized, they were having persistent symptoms for several weeks. And in April is when the lay press started to publish first-person accounts of protracted recovery. And in May, actually one of these groups from the Body Politic website, led by Hannah Davis and others, posted results from their first internet-based survey of people, and it covered hundreds of people and identified over 50 long COVID associated symptoms. And the hashtag long COVID was first used. And then in June 2020, Ed Yong published the first of a couple pieces in the Atlantic, just calling attention to the fact that there was this long COVID phenomenon. And in July, that was the first peer-reviewed manuscripts describing post-acute symptoms and sequelae, both in post-hospitalized people, especially from Italy, and then also non-hospitalized people, which was data from Mark 1040 in the United States, and followed briefly after that by Paul Blair here from Johns Hopkins in his and Yuka's cohort. And then in December, surprisingly and amazingly, Congress appropriated over $1 billion to study long COVID and its pathobiology. So, things have been hampered a little bit by the fact that there hasn't been a clear definition of long COVID or post-acute sequelae of COVID-19. So the World Health Organization convened a group that had a very kind of rigid, process to come up with a definition, and they released it in early October of last year. And so they're defining post-COVID condition as people who had a history of probable or confirmed SARS-CoV-2 infection, usually 3 months or more from the onset of COVID-19, with symptoms that have lasted for at least 2 months and can't be explained by an alternative diagnosis. And they go on to list a couple symptoms. And then they also highlight that symptoms can be new after acute illness, and that the symptoms can fluctuate or relapse over time. The CDC's definition is a little bit different. This was posted several months earlier, and they use the term post-COVID condition as an umbrella term to describe a wide range of health consequences that last basically 4 or more weeks. So kind of to summarize, the World Health Organization is defining PASC as 3+ months out with at least 2 months of symptoms, and CDC is defining this as greater than 4 weeks. So this is, there was a nice piece in Nature Medicine, or a nice review from early last year, put together by groups from all around the country. And this is a particularly nice graphic that I like. It kind of shows the time course of acute and post-acute SARS-CoV-2 infection. So here, starting this dotted line here is the date of symptom onset for symptomatic patients. Showing this in purple is kind of infectious virus or virus culture positivity. And then in green here is showing viral RNA detection from respiratory sites like the nose and saliva. And then they highlight here kind of 4+ weeks later that in a time period where most people, not everybody, but most people become PCR negative from upper respiratory mucosa, now have a whole host of symptoms that either continued from acute infection or arose after acute infection. And since in the last year, there have been many studies kind of characterizing PASC or long COVID. And this is one of my favorites. This is a group with Al Ali, and they used the US Veterans Health EHR basically to interrogate over 120,000 cases of people with SARS-CoV-2 in their system and compared to over 4 million people who did not have SARS-CoV-2, both before and after the pandemic. And they're looking here at the risk of people who survived 30 days after their COVID diagnosis. So they didn't die during acute infection. And they're now looking at 6 months past their SARS-CoV-2 diagnosis. And they're looking at their relative risk of having all these symptoms. And you can see, some of the most common ones are the ones that you've heard of, like fatigue is here, sleep difficulties is here, hyperlipidemia, which is not surprising because that's also actually seen in myalgic encephalitis or chronic fatigue, thromboembolism, chest pain, shortness of breath. So you can see all of these symptoms are much more likely to happen in COVID survivors. And this is 6 months later. You can also see here, what's great about this is you see the burden per 1,000 persons. So this is reaching about 3% of people are having shortness of breath. And this included mostly people who were non-hospitalized, but also had a large contingent of people who were hospitalized during their acute COVID-2 infection. I want to just emphasize that these EHR-based studies probably are an underestimate of people who are suffering from PASC symptoms. So it's also important to look at kind of prospective studies that have unbiased symptom screens. So this is getting closer to that. This is actually Hannah Davis's paper collating all the information from those surveys over the first year after SARS-CoV-2, and just showing that these are the symptoms that people who are experiencing symptoms for more than 6 months, these are the top ones that people experience. So fatigue, post-exertional malaise, brain fog, headaches, memory issues, insomnia. So you can kind of get a sense of what people are mostly complaining about at this point in time. And then I just wanted to note that it's important to realize that long COVID symptoms can wax and wane. So people can have days or weeks where they feel great, and then they can have periods of time where then things relapse and they feel worse, or they get new symptoms. So I think probably most of you heard about this. This was Paul Garner, who is a British ID epidemiologist and professor, got SARS-CoV-2 early on, I think in March, and he published a piece describing what it felt like his post-acute course. So his symptoms lasted for months, saying each day featured a new and disturbing symptom. And when he thought that he was feeling better, the symptoms would come roaring back. It was just nice to have this kind of patient perspective. It's deeply frustrating. A lot of people start doubting themselves, and their partners wonder if there's something psychologically wrong with them. That's kind of a little graphic of how things can wax and wane. And then to kind of talk about the scope or the magnitude of this problem, this is huge. So the Office of National Statistics in the United Kingdom does, I think, semi-monthly surveys on all things related to COVID, including long COVID. So they reported out earlier this month that in their December survey, 1.3 million, so an estimated 1.3 million, they did a representative sample of the UK population. 1.3 million people in the UK are estimated to be experiencing long COVID symptoms at that time in December 2021, greater than 4 weeks after infection. And that's 2% of the population. The population is about 60 million. And then of those people, 70% were 3 or more months out, and 40% were 12 or more months out. So this is really, people are still not feeling good a month later, a whole year later. 20% of those people said that their ability to carry out daily activities was limited a lot. Through EHR studies, we've also gotten another estimate of what the burden is at 6 months. So there's been 3 or 4 studies. If you kind of put their estimates together, the overall burden at 6 months post-COVID infection is about 4 to 10%. So 4 to 10% of people will still be experiencing symptoms later. And as I'll talk about later, the likelihood of your having long COVID is very highly associated with how sick you were in acute infection. So this is the US Veterans Association EHR study showing the burden per 1,000 people and number of sequelae if you were in the ICU here in purple, or if you were hospitalized here in orange, and then if you were non-hospitalized here in green. This is kind of another way to look at how many people are experiencing symptoms at different time points. So this was a systematic review of COVID cohorts. And it's nice because you can see, if you look at individual cohorts, so, you get different percentages of people who are not feeling good at different points. So this is kind of a nice summary of all of those studies. And these are nice too, because most of these are prospective studies, although they're biased by who remains in those studies and also by their own selection of the people in those cohorts. So you can see this long-term, this encompasses 3 to 6 months after COVID infection. So you can see there's some studies down here at about 20%, and then some studies up here at 75%. So I can just tell you that in Yuka's cohort of prospective cohort of COVID patients, we see about 50% of people who are still having symptoms. So we're kind of within that range. This is just a snapshot of data from Yuka's COVID cohort. It's called Outsmart. So in this cohort, people are recruited within a day or two of testing positive within the Johns Hopkins healthcare system. They and everyone in their household is recruited, and acute sampling takes place, and then there is longitudinal sampling at 1, 3, 6, and 12 months. And these are tied to symptom surveys that are pretty in depth, and I'll talk about those later in the context of my HIV study. But here is this is a snapshot of about 42 people out of about 90 that returned for a 12-month visit, and about 54% of those people at 12 months were still having symptoms of COVID, of long COVID. However, you have to keep in mind that these were the people who chose to return, so they're probably biased towards people who are not feeling well. And so you can see we had a 5-point Likert scale of all these different symptoms, and the darker the color, the more severe, basically, they said the symptom was for them. And so you can see fatigue was the most common symptom experience, and then problems with concentration or brain fog, difficulty sleeping, anxiety, and then upper respiratory congestion remained for a lot of people, and then different types of pain. You can kind of see the whole list here. So what are the risk factors for long COVID? So like I mentioned before, the severity of acute COVID-19, your baseline health status, that's been shown in nice large EHR studies. If you're unvaccinated, and your age also matters. Female sex matters too. I'll talk about that a little bit. And there's been some small studies showing that elevated BMI is also a risk factor. So this is a report from last fall. This was using the COVID symptom study app. So this is a cool app that a lot of people in the UK and some people in the United States and Sweden have been using. They published some pretty great data looking at symptom duration and which symptoms people have. But they also collected information on whether people were vaccinated before they got COVID, so whether they had a breakthrough infection, and whether they were vaccinated once in red or twice in blue before they got their breakthrough infection. And then these are kind of the odds of all these outcomes. So you're much more likely to have an asymptomatic infection if you have 1 or 2 vaccines. And then here's kind of the key thing for PASC. So you are less likely, I think, let's see, yeah, basically having 2 doses probably protects you, and the effect they saw was about 50%. But it seemed that one dose of the vaccine did not help. And there's been a couple studies since then, and there's actually a nice piece in yesterday's New York Times outlining the different studies that are looking at long COVID and the vaccination status. And then in a different study that I don't have up here, the likelihood of long COVID was reduced by 10 times or more if you were vaccinated. So we think that being unvaccinated is a risk for long COVID. Then there's a couple others. So this is another study, a separate study from the Al-Ali group, looking at your risk factors of having all of these symptoms at, I believe, 3 months, depending on whether you were hospitalized in orange, in the ICU in purple, or whether you were not hospitalized in green. And you can just see your risk factors for all these things are elevated if you had more severe acute infection. So female sex. So this is kind of a, so that's clear. And many studies have shown this association with severity of acute infection. So female sex is another one. I think, I'm sure Eileen probably has noticed these studies. I know Eileen and Sabra have been doing great work on sex differences in acute COVID-19, but I think the story there is probably a little bit more complex. And the early studies were showing that PASC patients were more likely to be female. But another large study by this Al-Ali group looking at the US VA health system showed that there are sex differences by symptoms. So females were more likely to have symptoms such as, I think, headache and difficulty concentrating. And then males were more likely to have other symptoms like fatigue, which is interesting. So I think, and then in our own study, so when Paul Blair looked at, this is Yuka's cohort, when Paul Blair looked at 28 days to 3 months later, people who had longer time to recovery were more likely to be female. However, now that we have more patients and a longer follow-up time, I'm not showing you the survival curve, but we see that there is a difference in time to recovery, but that difference occurs basically between day 28 and month 6. And then we don't see a sex difference after month 6. That could also be because we're still collecting patients after month 6, so we'll get more patients and see about that. But not every study shows a sex difference. So this will be really interesting to tease out to see what are the differences based on sex. You can see here, this is looking at age group and the odds ratio of having kind of long COVID after 28 days. This is from the Symptom Tracker app study. And so, you are more likely to have long COVID the older you are, and other studies have shown that as well. In terms of overweight obesity, there's been only kind of 1 or 2 small studies showing that obesity matters, but other comorbidities do matter. And the number of comorbidities you do have matter. So if you have more than kind of 5+ or your Charlson score is high, that's clearly more associated with long COVID as well too. So the duration of long COVID. So I'm just showing you kind of a survival curve here on the left from a nice paper published in CID of a prospective cohort of 342 Dutch people. And again, showing that there's a difference in duration depending on your status for acute infection. And you can kind of see how many people are recovered by about 90 days, by about three months. You can see it's about 75% of people who were not hospitalized, and then much less for people who were. And this is one of the studies that did show a difference by sex and by obesity as well too. So kind of to summarize, it's important to know that symptoms can wax and wane. Other times they persist, that new symptoms can develop even months after acute COVID-19. And then a kind of a key pearl is that even people who had asymptomatic acute infection, some of them can develop new symptoms and have long COVID. It's rare, but it can happen. And then right now, the severity of acute COVID-19, that's the best predictor of the duration of long COVID. And ongoing studies will kind of better characterize this 6 to 24 month trajectory of long COVID. So I wanted to talk a little bit about clinical management before talking about the study that we're doing. It's important to know that there is a place to refer people who have long COVID. If you are struggling with taking care of them, that's, I think, the most important thing that I can say. And one of them, probably one of the best in the nation, is here at Hopkins, and I'll talk about that too. So post-COVID clinics are in nearly every US state. You can find them through this website, this survivorcore.com. You can type it in by location and find referral information there. So these are typically multidisciplinary clinics led by people who are experts in ICU recovery and PM&R. they can provide disease-specific expertise and referral to specialists, research, resources and support for patients, and linkage to research. These are pretty great. And then this is just a slide about the JH Pact Clinic. So this was started by Anne and Emily in Alba, and Emily Brigham has left us, unfortunately. So it's being co-led by Ann Parker of Palm Critical Care, who has an expertise in post-ICU care before this, and then Alba Zola, who is a PM&R physician and researcher. And so there's a nice website. I've put the URL down here so you can find it. And they are staffed by pulmonary and PM&R physicians. At the beginning, they were all telemedicine, but I think now they are also seeing patients in clinic. They can refer to home care, including rehab, nursing visits, and they can refer to on-campus rehab services. And importantly to specialists, and even ID specialists. I think there's been specialists in basically every affected division or department of Hopkins that have been brought in to see patients in the JH Pact as part of that. So it's important to know that physician referral is required. The patient cannot just go there by themselves. And then how you do that, again, this is the most important thing I can say, is by emailing. If you want to refer someone, email this website, and you'll get a response from basically their nurse manager and/or Ann or Alba. So when to consider referral, and I'll also talk about this later, but they specifically say that if someone had an ICU stay for more than 2 days, that's someone who should be considered. If they had serious acute illness or they were hospitalized and they're having significant persistent respiratory symptoms or new increased oxygen requirements, if the pulmonary consult during the hospitalization actually recommended Pact Clinic follow-up clearly, or if the PM&R consult recommended post-discharge rehab. Those are people who I think are people that they are very happy to see. And then if someone was not hospitalized, they do see a number of these patients, although it's a minority, I think, of the patients they see. So if you have someone who's never hospitalized but is having persistent symptoms for 2+ months, and you need help, you can email them. And typically, I've done this before, and they will suggest a couple things that you can try before referring to them. So again, these are clinical management suggestions. These are based on the UK's NICE guidance. So one of the first important things is to just to identify patients who might be suffering with this. So, and we're not going to identify them if we don't ask about it. So suggest that you bring patients who are post-hospitalization, especially from COVID, into clinic 6 to 8 weeks after discharge, and ask them about symptoms that they're having. If you can find screening questionnaires, I'm providing kind of a reference to one that is a good one. And then, discuss with your patient using shared decision making just to determine whether further workup and assessment is needed. Always do a comprehensive clinical assessment exam, discuss how these symptoms are affecting the person's life and activities. And if cognitive difficulties are brought up, you can use a validated tool for assessment. So the GP-COG is one of those, or the MOCA. So you have a couple options. Clearly, if there's life-threatening or severe disease, you can refer to the ED or to the appropriate specialist. So for example, hypoxemia, cardiac chest pain, multi-system inflammatory disease in children or adults, and of course, severe psychiatric symptoms or risk of self-harm or suicide. I haven't mentioned this specifically, but mood disorders are associated with long COVID. So think of and rule out alternative diagnosis, consider blood testing. If appropriate, you can offer an exercise tolerance test, and rehab physicians, or so that can be done through rehab if needed. If you suspect POTS or other autonomic dysfunction as a screener, you can obtain orthostatic vital signs. There is a post-COVID POTS clinic here at Johns Hopkins. I'm not sure the waiting line for that, but you could get information about that also from the Pact Clinic email address. Getting X-ray as needed if post-discharge respiratory symptoms are present for a prolonged time. Refer for treatment or therapy for anxiety or mood disorders. This can be important for patient quality of life. And then, of course, consider referral to the Pact Clinic here. And then just important to note, don't exclude people from referral if there's no hard evidence that they had SARS-CoV-2 infection. I think this was probably a little bit more relevant at the beginning of the pandemic when a lot of people didn't have access to tests. But it may also be true now when I think there has been shortages of tests nationwide in the past couple of weeks. So someone may have realized, a couple of their family members tested positive and they have the same symptoms that they probably had COVID, and so they never bothered to get tested. But it's important not to exclude those people from consideration and treatment. So this is, again, from this nice Nature review, Nature Medicine review, with kind of suggestions for a follow-up of different types of symptoms here. Just put that up as kind of a resource that you can check that out later. And it's important to know that patients really want follow-up and communication. This was a paper looking at patient experiences of long COVID. So many patients feel isolated and fearful with scant information about community resources and little safety net and advice. People in this survey expected more from their primary care physicians, with over half wanted to hear from them with phone calls and follow-up from nurses and doctors as the most important approach in their recovery. So it's also important to know that long COVID is now officially a disability. So as of July 2021, it can be considered a disability under the ADA if it substantially limits one or more major life activities. Major life activities can include a wide range of activities: caring for yourself, eating, sleeping, standing, concentrating, thinking, for those with brain fog, writing. And there's a definition of substantially limits. So kind of to summarize management, multidisciplinary post-COVID clinics are available in almost every state, including a fabulous one at Johns Hopkins. Be sure to follow up with patients. I think that sometimes witnessing recovery is actually the most important thing that we can do as physicians, even if we're not actually doing anything for them. So it's important to try to talk to your patients and see how they're doing. And of course, refer to specialists or the ED as needed, consider these testing, and know that it's a disability and don't restrict access to people who didn't have positive tests. So I'm just now looking at the questions here.
I was just going to say, if we could just take a minute to answer. I think Stu was asking if there's a MyChart questionnaire that's sort of set up for these past questions.
I know that Ann Parker was working on that, and Kelly, I don't know if Kelly Gibo is on here. She probably would know that as well. Wait a second to see if they're on. I know they were working on that. I just don't know if it's up.
And then the other point was from Jill Crank, just that the wait for the Pact Clinic is more than a year, and the Pact Clinic is about 3+ months. And yes. I just wanted to piggyback on that with the question of like, you've thought about this so much. So when you think about it, how much of this is management of things that happened from having an infection that are now happening and sort of independent of that? And how much of this is an ongoing pathology, sort of thinking like you have a stroke and then you have a deficit versus you have something that triggers an autoimmune disease and you have a continuing ongoing process that's specific and autoimmune. Because like, just in terms of, could you go to regular pulmonary clinic as, like in thinking, troubleshooting on how to get patients who have symptoms, and what's your sense of how much of this is an injury from an infection that has persisted versus an ongoing process that needs like tailored therapy?
Yeah, so those are fabulous questions. So the first thing I want to address is that if you have a patient who is suffering, still email that Pact email address. So don't be afraid by these wait times, even because they can give you advice basically, and they can give you suggestions on how to manage this patient in the meantime. They know kind of what their waiting list is. They know when they'll be able to see the patient. And so I've gotten great advice from them just over email. And I have also referred patients to the pulmonary clinic. This has been more often if the patient's not part of the Hopkins system, but yes, you can definitely refer to others. So the most important thing is to try to access care. This POTS clinic, I know that the waiting list, that's really tough. The regular POTS clinic also has a waiting list of a year too. So, I think anything that if you're worried that your patient has POTS, I would also email that Pact Clinic and they can put you in touch with Tay who could give you other recommendations in the meantime. So then the very interesting question that, Eileen is thinking about pathobiology of PASC, and so is, many people on this phone call. And so I'll tell you, so I was hoping to include a couple of slides, like maybe 4 or 5 slides on the current state of knowledge of the pathobiology of PASC. And there are about, let's see, I'd say about 4 to 5 papers that address this. And these are from UCSF and Australia, and then I think a group in the United States and China. So the thing that I've noticed, so what these are doing are they're trying to correlate symptoms or imaging findings in long COVID patients with immune markers. And I would say most of these studies, they see various forms of immune dysregulation, whether it's upregulation of pro-inflammatory cytokines or upregulation of exhausted CD8 T cells, or seeing basically, different subsets of populations that are corresponding to PASC. But the cool thing is that it seems that you can't distinguish these people at the 1 to 3 month mark, but when you hit 6 months, 4 to 6+ months, that's when the people who have long COVID seem to be different than the people who don't. So these markers seem to have been elevated from acute infection, and then they're going down in the people who have full recovery, and they seem to be still elevated in the people who have PASC. So based on that, I think it's more likely to be the first thing that you said, which was that this is an insult that is taking either a longer time to recover, or there's kind of chronic inflammation at the tissue sites that is driving these changes. So the other possibility, among many, is that this could be a triggered autoimmune reaction. And I had a nice conversation with David Block about this over email this week, and a lot of people are thinking about this. So I think that is definitely still possible, and it's probably true in a subset of people, right? I haven't seen any data that this could be the case in long COVID, but I think these studies are actively going on. Within Yuka's cohort, we have pursued this. So we've looked at 3 different panels of autoantibodies. This was run by the Rosens here at Johns Hopkins. And then we also worked with Ben Larman to use MIPSA and FIPSEQ to assess these samples to see if we can see any kind of patterns of autoimmunity to self-peptides. And we haven't seen anything so far, but I think these studies were all looking at symptoms at 1 month in COVID survivors. So actually, after reading these papers, I'm realizing, oh my gosh, we should go back to this data that we collected and then see if this predicts their course at 6 or 12 months. So I think, or use 6 or 12 month samples to do these assays. So these are kind of investigations that are still kind of going on at Hopkins. And I think there are many other groups, including, I know the Link cohort is pursuing this. And I think Akiko's group at Yale is also pursuing this as well too. So we'll see.
Can I just ask one more question? Just in terms of the transplant community, I didn't see that as a risk factor in some of your earlier slides, but I may have missed it. But I'm just wondering, do people with severe immune suppression, they tend to get severe COVID, but also have all sorts of other modulation? Are they represented in these long COVID cohorts or not? It doesn't happen as much.
You and others are much more knowledgeable about kind of transplant and immunosuppression generally in COVID-19. I haven't been looking specifically for that, but it also hasn't stood out to me. But I haven't done a deep literature review just to look for that. You know what I'm saying? So I'm not sure.
Okay.
I don't know.
It might be interesting with some of the transplant colleagues because they follow their patients so closely, and to see if they have some of these persistent symptoms or if it's less common among them. I think there's some people from the transplant group on. They should feel free to.
Yeah. I don't know. Is anyone on here? Would anyone like to comment about long COVID in the transplant population?
One might consider me part of the transplant ID group. It's not something we focused on, and part of that is we've been so hyper focused on keeping them protected and not dying when they get COVID that we have not done a lot of follow-up afterwards. I can say give a couple anecdotes. I've seen people totally recover and get back to normal, and I've seen people who have sort of lingering respiratory symptoms as their main complaint, or abnormal changes in their CT scan. But when we've been involved in those cases, it's usually been to suss out some, super infection or secondary infection that's come either due to their acute presentation or the immunosuppressive agents that we have used to treat them. So, our group, Nate in our group and Kieran have looked really extensively at CAP or fungal infections after or with COVID. But that's sort of a distinct clinical entity. But I think it's a great question. I think we do have a ability to follow these patients, and I will ask my colleagues if they've come up across anything like this.
Thank you, Andrew. Yeah, at the beginning when it was described that certain people with immunosuppression had prolonged viral replication and viral RNA, I did look at all of those case reports, I think up through like October, and many of those people were asymptomatic, but some of them went back to the hospital. So I don't know, like I didn't get like a sense from that, how that might look. But again, that may not be, it's not similar necessarily to the transplant population, as a lot of these people were kind of B-cell deficient. So that's a really good question. And actually, I wonder, Andrew, in the kind of vaccine surveys for this transplant cohort that kind of you and others are doing, are you asking symptom questions? Are you following people up if they get infected and asking symptom questions? Like, do you have the ability to look at this?
Bill Werble would know that better than I do, because he's the PI of the observational study. I know for the clinical trial, which is a much smaller group, we absolutely have the ability to do that, but the number of breakthrough infections has been thankfully somewhat small in that study. So we would have to talk to Bill about how much data we have on symptoms with breakthrough infection in the observational cohorts.
Okay, well, that's cool. So you might be able to do that. And then I'm seeing Yuka's comment here. Yeah, so this is a really important point. So I'm not also mentioning, I feel like some of the most exciting data that Yuka's cohort has generated, which is we gave samples, and I'm not showing this because it's not necessarily my data to share, but we gave samples to Andrea Cox and Liz Thompson to do their immunometabolic flow cytometry profiling. And the word on the street is that there's a couple, if you look at it, not based on total symptoms, but if you look at it based on specific symptoms like fatigue, difficulty sleeping, which overlap, upper respiratory congestion, and I think we had brain fog. And so if you look at some of them, but not all of them, there are distinct clusters with metabolically dysregulated B and T cells. And so they're following that up right now. But that's potentially very exciting. And so that's speaking to what Yuka is saying, that some of these autoantibody studies that we were just looking at symptom scores. So we probably need to go back and break it down, look at longitudinal follow-up. Okay. All right, I'll just continue if that's okay. Oh yeah, so this is a really cool slide. This is resources for patients, a bunch of websites. And then importantly, support groups. So if your patient is feeling alone, I would direct them to one of these support groups. I'm showing the logos of most of them here. And if they want to participate in research, there's a lot of research at Hopkins, and then this is the large kind of NIH Recover study. So I just want to say for 1 second that, Recover is this giant, this is the $1 billion that NIH appropriated, and it's going to a multi-center cohort study. And Kelly Jibo successfully wrote a grant to look at autopsies of people who are post-COVID. And I think whether or not that grant is going to be accepted at Hopkins is up in the air, kind of based on funding lapses and things like that. But that was a successful grant that came from Johns Hopkins. So that was terrific. And I just also want to highlight that there's a lot of long COVID research being done at Johns Hopkins. And so this is the JHU PASC Collaboratory. So if anyone is interested in the research of PASC, please email Kelly Dooley. And I know Kelly is providing leadership for this, together with Kelly Gibo and many others. And this is a list that they compiled for this month of everyone who has an IRP approved or submitted study for PASC research. So there's quite a bit of people here. So then I want to just take the last 10 minutes or so to just go over my particular study. So this talk was entitled Long COVID and HIV, and I have nothing to say about long COVID and HIV except for that this is what we want to study. There's nothing in the literature about this so far. There is some great kind of post-COVID immunity work, so looking at antibodies after COVID in people living with HIV or after vaccine from other groups, including the clinical trial groups. But there's no specific long COVID study that I'm aware of that's peer-reviewed so far. So with this study, this was funded by Antar early last year with a large grant and with the aims to formally and prospectively characterize symptoms and sequelae of post-acute COVID-19 in people living with HIV as compared to people who are HIV negative. And so we're powered to see about a 15% difference in incidence. So we'll see about that, but it's also to identify blood-based biomarkers or immune signatures associated with prolonged or persistent post-acute COVID-19 in people living with HIV in comparison with the general population. We want to catch people within a month of their SARS-CoV diagnosis so that we can get a month 1 blood time point, because it would really be amazing if you could do a simple diagnostic test at 1 month and be able to predict how long someone is going to have long COVID. That might be important if there are therapeutics down the line. So you could say, well, you know, if you take this therapeutic, then maybe you'd be a little less likely to be experiencing this a year later. So that's why we're trying to catch people very soon after their SARS-CoV-2 diagnosis so we can get that early time point. So I'm lucky to be the PI, and the co-investigators are a great group. Alan Landay at Rush. He is the biorepository and the fount of wisdom for this study. And then Michael Peluso, who's amazing, who's essentially running and leading the LINK cohort, which is UCSF's NIH-funded long COVID cohort. We are working with a network of HIV and COVID investigators around the country for referral and for advice and guidance. And our senior study coordinator is Nuria. So we hypothesize that people living with HIV are more likely to experience persistent symptoms than most HIV negative people, and that persistent symptoms are associated with a dysregulated immune signature. So for this study, participants have to be 18 years or older. They can live anywhere in the contiguous 48 United States, so not Alaska, not Hawaii, but anywhere else. And that's because we employ Exam One, which is a mobile phlebotomy company. So wherever you live in the United States, they will come to your house and draw blood. They'll do your vital signs and weigh you and measure how tall you are as well too. So this is kind of exciting because we're not limited in where we can see patients. So this study is fully in English or Spanish, thanks to Nuria and other people who are part of our team. And they must fall into one of two groups. Either they have never had COVID or they don't think they had COVID. You know what I'm saying? If someone is pretty sure they had COVID but never got tested, but they're pretty sure because everyone else around them tested positive, we probably don't want them. So we want them someone who has never had COVID. And then the COVID positive is someone who's having their first COVID infection in the last 4 weeks. So these are the study groups in our kind of target enrollment. So for COVID positive, we are trying to recruit 110 people living with HIV with recent COVID, and then 110 HIV negative people with recent COVID. In the second arm, this is kind of a control group of people who are COVID negative. We want 45 people who are living with HIV who've never had COVID, and about the same number of people who don't have HIV and also never had COVID. Unfortunately, because of Omicron, we had the opportunity to enroll more patients this month. So I think we're going to get close to about a third full from the study, and we're running through at least the end of this year. So these are the study events. This is for people who are COVID positive. We try to enroll you within 4 weeks of your diagnosis or symptom onset. We have a baseline questionnaire. It takes about maybe 10, 15 minutes to do it on the phone or over the internet. And then around month 1, give or take 2 weeks, there is a visit by the mobile phlebotomist that will arrange. Again, they can go to the patient's house, or they can, if the patient wants to come to an Exam One location, it's a subsidiary of Quest, so they're often co-located with Quest Diagnostics. They can do that, or they can find a neutral place, or they can even do it outside. So wherever the patient wants to have their blood drawn is fine, but it typically has to be within the work week. but that, they could go to the patient's workplace if that's allowed. So they do, they measure height and weight and do orthostatic vital signs and collect blood. Then we have a kind of either a phone or internet survey at month 2. At month 4, there's a blood collection and surveys. And then month 6 and month 12, we have surveys. Also important to know, we partnered with Tracy Vandersdahl here at Johns Hopkins. So we're doing telephone neuropsychological batteries at month 1 and month 4, kind of tied to the blood work. And so that's so we can actually more objectively look at the different domains of cognition that could be impaired. So these are the events in the COVID negative arms. So in the COVID negative arms, we're only drawing blood on people who are living with HIV, and we're only drawing it once. But other than that, they have all the surveys that everyone else is doing at the same time points. So participating involves completing 6 surveys about symptoms, health, quality of life, sleep, and fatigue. And then the 2 neurocognitive batteries. Together, so it's only done twice, this like neurocognitive battery plus the survey, and that takes about 60 minutes. So it does take a while. And then these 2 blood draws that are at the same time as that long survey and battery. So this is what we ask about. So we ask about your COVID course, when you were infected, whether you were hospitalized, what happened in the hospital, did you need oxygen, things like that. And then we ask your vaccination history. We ask every time to capture them as they get vaccinated or boosted. And then we ask a lot of questions about HIV history for the people who are HIV positive. And then we do actually the same symptom surveys that we're doing in Yuka's cohort. So we do a 5-point Likert scale with 49 symptoms that's based on the Flu Pro Plus. We do a 36-item quality of life survey. We do sleep and fatigue if people complain of that with 2 validated tools, the Insomnia Severity Index and the Fatigue Severity Scale. We ask questions about respiratory function and pain. And then mental health, we do the GAD-7 and the PHQ-8. And then we partnered with Leah Rubin to also offer kind of a different brain health questionnaire that she uses. And then we ask questions about their medical history, diet, exercise, and drug use as well. In terms of data collection, we do clinical lab tests on the blood that's drawn, the CBC with DIF. We do CD4, CD8 counts for people who are HIV positive. We do HIV antigen tests and antibody testing if they say that they're HIV negative. Actually, I think we might be doing that on everybody. But and then we, as a first pass, we do the SARS-CoV-2 anti-nucleocapsid IgG that's on the Abbott platform. We do a D-dimer, a high sensitivity C reactive protein, a CK, and a lipid panel. And these last 2 were included because these were seen to differentiate people with ME/CFS versus others. But also in some of these large EHR studies, it's been noted that there are cholesterol tests being abnormal is actually like a very strong predictor of people who have long COVID. So I'm glad we ended up including those. Vital signs mentioned, and then planned analyses, we're going to do kind of cytokine chemokine panel. We're going to do multiplex antibody and pseudo-neutralization assays on an MSD platform, thanks to Alan. And then we're collaborating with Adaptive Biotech to do TCR beta CDR3 repertoire sequencing. And then excitingly, they're gonna release their COVID classifier results to us. So we're gonna get back which TCRs are SARS-CoV-2 associated and what viral protein they bind and whether they're associated with CD4 or CD8. And open to your ideas also, because these haven't, we're still collecting samples, so we haven't actually started running those assays. So the participant experience, just finish up in 1 minute. The study is fully remote. All study events can be completed from home. Patients will get up to $100 if they're COVID positive, and that's $25 for each neurocognitive battery, and then $20 each for each blood draw. And so they'll get that within the first 3 or 4 months of the study. People who are COVID negative will receive a little less money, either $50 or $75, depending on whether they get 0 or 1 blood draw. And these are given in the form of gift cards. And then this just tells you how long the surveys take. So as Eileen referred to, and I also often refer to, please refer to us. So if you have a patient that is recently diagnosed with COVID, or you have a patient who's itching to do research, they've never had COVID, they want to be part of our negative arm, you can, as long as they give you permission to talk to us and you document it in your note, just in a sentence, just say, patient granted permission to talk to the long COVID study or whatever, then you can email me with a secure tag on the subject line. You can email me or message me on Epic with their information. You can also direct them directly to our website, covidrecoverystudy.org. And there's a kind of a HIPAA compliant red cap enabled like form where they can submit their own contact info in English or Spanish. And then we have an email and a phone number that they can text or call. So last slide, just wanted to say thank you so much to so many people here. Bob is the original person who actually referred Antar to me, and then have gotten a lot of help from Heba, Ali, my GCI, Jeannie, Richard, Leah, Tracy, and Yuka. A lot of support from JHU CFAR. So the major funding was provided by Antar, but we've gotten some support also from the CFAR, both in personnel and in and as a mini grant to our medical student. And then many people here at Hopkins outlined here, including a really wonderful medical student, and all these people listed here, and then all these people listed down here. And we've actually gotten a lot of advice and help from multiple community advisory board members and people involved within HIV nonprofits. And that's also through networking through Antar and through our other co-investigators.
Well, thank you, Annie. That was tremendous. If you get a chance to look at the chat, you'll see it's full of lots of people saying how amazing you are, which this was really fantastic. And also just, one of my concerns with the patient led cohorts is that it may miss a lot of people like our patients. And it's just so great that you're recruiting from our clinics, and hopefully we can do as much as we can to support you to make sure that you get the data that we need to help take care of our own patients. And the only way we can do that is if they're included in studies. So thank you so much for doing this. And if anybody has questions, there's a few minutes left, so please unmute. Everyone just wants to say you're great.
Oh, thank you, everybody. I've gotten so much help from everybody and so much support. So I really, really appreciate that. Thanks for listening.
Okay, so we'll all just refer everybody to Annie. And especially women. Remember, HIV studies in the United States never have women. So let's give her everybody we can.
And I'll post these slides in Teams. So
awesome. Thank you so much.
okay, thank you, everybody.